Thank you, Nancy and Connie. This is the time where we are now open for questions from people from the audience. And again, if you are watching online, just click on the link and we will be able to get to those questions as well. But we'll start right here, right in the back.
Two quick questions. First of all, you talked about when providers fail to do cervical cancer screenings in the office. Did it depend if they were seeing a nurse practitioner, specialist, internal medicine, or family doctor? And the second question is hepatitis B is a sexually transmitted disease, and there's no real controversy behind hepatitis B vaccines. Why the heck can't we do this with HPV? Is it the internet? What's going on? Like, why is this different than it was when we rolled out HPV? Thanks.
Your first question is relatively straightforward. The question had to do with, does the likelihood of getting screened depend on the characteristics of the provider? And we think it does. So one of the questions we're asking now is we're looking at how far the person is out from finishing their training as a proxy measure of. We're also looking at subspecialty.
Do you want to do the Hep B question?
The Hep B question. If I was king of the world and was in charge of marketing, I would have marketed it as a cancer vaccine.
Yeah, I've said the same thing from the beginning. I agree. So why it didn't turn out that way, I have no idea. And maybe somebody does, but I don't know.
Hi, my name is Jeff Kaplan, and I'm an internist in private practice, but I also run the Public Health Committee for MedChi, the State Medical Society. And so I think that I'd like to give a provider viewpoint. First of all, I'd like to clarify the point about internists don't do office gynecology. We don't. It's family practice and, of course, gynecologists. So as a group, we're not there to do that kind of screening. Certainly in my internal medicine residency, that wasn't part of my training. That was several years ago. I currently am not aware that it is part of the training, but I just wanted to clarify that. Right. So it's now being, internists are now doing it? Not everywhere. Okay. Okay. So I wanted to do that part of the screening, but the other thing is having to do with where the vaccine is administered. And I think that's a very important point, because if the targeted group are 11-year-olds, I've talked to my pediatric colleagues, and it doesn't appear that there are any other routine screens that get done at that age, and therefore one of the difficulties have been, and there have been studies to show that the intersection of girls coming in to the pediatrician is apparently there are like 5 lost visit options to administer the vaccine on top of what is usually not a well visit. They don't have that many scheduled well visits. So at that age, they're in the transitional age, and usually they then go a bit later to see the gynecologist. And I don't know the experience of the gynecologist if the first visit is often before initiation of vaginal sex or after. So then we have that other provider interface, and which is the most useful one to be able to have and administer the vaccine. Well, I'd like to put a different viewpoint on that, because this is where private health in the US and public health are giving too much importance to the role of private providers in administering the vaccine. So I've looked at the results internationally of the success of HPV vaccine uptake. And as you were showing, in America, the statistic is perhaps a third actually get all 3 vaccines. And at one point, and I have a study here that shows in 2008, it was like 18%. In other countries, Belgium was 44%, in Australia 66%, and in the UK it was 80%. What did the UK do that was so much more successful than we are and than we will ever be if you come to entirely rely on the provider community to vaccinate? And what they did is they gave it in the schools. And that's the important thing, is that if we want to have a successful way of administering this vaccine to a huge number of girls who are at risk for cancer, we have to think of having school-based delivery of the vaccine. 90% in the cohort of 11-year-olds in England got the first vaccine. 80% got all three. That's incredibly successful. And so we need to really think that we need to try and have mandates. I'm entirely in favor of mandates. I find that the arguments that this, for example, that might provoke a backlash against of anti-vaccinationists, we should be strong enough to be able to make those points. But we do need, I think, to look at school-based programs. It's important. This is a very expensive vaccine. This costs $300 to administer all three vaccines. I'm a primary care physician. I'm an internist. I have to put out, myself, $300 to buy the vaccine, and then I hold it, and then I have to administer it in the hope that I'm going to be reimbursed. Well, this is way too much. And if you look at how much it's going to cost primary care providers to put up front to buy this, to be able to cover enough patients, it's not going to happen through the primary private provider community. And of course, I'm sure that some of my colleagues would not want to hear that message because they like to think they can do this. The answer is no, you can't. And if we're going to devise successfully a program in the US, it should have a major component of being school-based.
I feel like that's mostly a comment.
Yeah, okay. Any other questions? Right here in front, if you could just please wait for the microphone so everyone online can hear your question.
Hi, my name is Megan Harris and I work for JPIGO. I work on international VIA screening programs and an HPV study in Thailand and Philippines. And you spoke a little bit about the mandatory versus voluntary situation in the US. And I'm just wondering, can you put that in the context of an international developing country context in terms of where cervical cancer, the burden is probably the highest? I was wondering if you could just talk a little bit more about that.
So in the largest sense, I think that the ideas are the same, but the way you answer it is, of course, going to be completely dependent to what the finances are locally and what the epidemiology is locally. So the burden is so much higher in other places, and I think what a lot of us would love to see is a rollout of a lot of HPV programs. There's a huge question about whether that comes through a donor base or whether it comes locally. If it comes locally, it's hard to believe it's going to make it very quickly given the cost and given the extraordinary competing priorities, and there are things that still aren't being done. We all know that don't cost very much and would make a big difference, and again, they're still not being done. And so it depends a bit if we look broadly or if we look narrowly. I mean, I do think that figuring out a way to get the vaccine far more accessible would be, I'm just speaking personally, the highest ethical priority before even getting to the question of whether it's mandatory or voluntary. It seems like the first thing that's important is making it available and seeing how the heck that can happen I mean, I sort of feel like the last comment ultimately was a systems comment, and to think about what are the systems and in part what are the messages. And I sort of feel like then down the road start to think through the mandatory question.
I was wondering if there's a difference in funding streams if something's mandatory versus permissible, and if, you know, making it mandatory would eventually drive down the cost and make it more accessible.
Yeah, that's a great question. So the big difference is between whether it's routine or whether it is voluntary. So when it's so it depends a bit on the particulars, and we're talking more about vaccines. But once it gets recommended, then it also goes in a category where it is where a whole bunch of payment programs kick in, and it gets included in the portfolio of things. It is also true that a state cannot require something to be mandatory without figuring out a way for people to pay for it if they can't pay for it themselves. But I think with vaccines, you hit that payment threshold before you get to mandatory. There are vaccine. Well, HPV is a good example. Right now, HPV is not mandatory in Maryland or in most other states, and it is paid for through all these vaccine for children programs, et cetera. So my point is that there's the steps that it takes to get a vaccine paid for through government programs and for insurance companies to start in parallel covering the same things happens before you even get to the mandatory threshold.
Okay, we do have some questions from our online audience, so I'd like to get to those for a minute. First is, I guess either for Nancy or Connie, what do you feel would be an effective way to increase Gardasil vaccinations in the MSM population?
You know, one thing that occurs to me is that the more routine the vaccine is for boys, it's a relatively recent change, that recommendation from the CDC that HPV vaccine not only be available for boys, but that it now be routine for boys. And I think one thing is the hope that it becomes a more universal message for boys that all boys should be getting this. And obviously that then will be protective for boys who have sex with boys, men who have sex with men. There certainly can be some pretty important messages in targeted health education. This is not the first time that public health has tried to do messages that target men who have sex with men, and using a lot of the same channels seems really important.
Sorry, I got stuck on the men part because, like any of us who are older and have already started having sex, it's the preventive vaccine it's not preventive anymore.
Yeah.
So boys.
It's relevant for the boys, yeah.
It's for boys.
Okay. That's another question asking, not all of the cases of HPV-related cancers are caused by the subtypes covered by the two different vaccines. Is there any concern about ecological replacement?
Yeah, that's a question that comes up fairly often. Obviously, we're getting data. But I think that the biology of HPV is that it's really indolent, and the likelihood that a strain that's genotypes that don't already cause disease would mutate to cause disease, I think that's really low, actually. So I know that vaccines are being developed to cover more genotypes. Having said that, and that coverage will depend on the epidemiology in different populations.
Okay. And this is actually more a comment from a practitioner in Madison, New Jersey. I believe that healthcare by internists should include recommendation for appropriate cervical screening if it's not being done in their office. And I used nearly 200 doses of HPV vaccine that I received through ARRA funds at no cost on a college campus in our municipality, going to where the students offering at no cost to the student, and having standing order to administer contributed to the success of the effort. Thank you. So, yeah, question right here.
A couple of comments and a question. Any new data about the duration of efficacy of the vaccine? You mentioned 5 years. And what are you going to recommend in terms of pap smear screening, when to begin that? Because if the efficacy is only 5 years, what will happen thereafter? That's number one. Two, I gave Dr. Cass a copy of an article, but I'd be interested in your comment on was out a diatribe against the HPV vaccine, which is terrible. The second one is there's a lot of discussion now about including HPV in Gavi in the sense to posit differential pricing of HPV vaccine. So the idea that it costs $300, very few developing countries will be able to afford a vaccine for $300. But there's intensive discussion now with the possibility of reducing the price of the vaccine. But I'd like to emphasize the point you made. It is not only the price, it's the delivery systems that really represent a major block all over the world. Having said that, I think it is barely fatuous to point to say that we must improve the delivery system before we give the vaccine. Well, life doesn't work that way.
The pap smear question.
And how long it will last?
We don't know. We're getting data. Now, the screening recommendations include for, I think, for non-vaccinated, just across the board, not to start until age 21 or the onset of sexual activity. And if a person has had sequential normal PAPs, it's okay to space out screening. In women who are over the age of 30, I suspect the screening recommendations will change to doing HPV testing, and the person will have to have sequential positive HPV tests with the same strain before being flipped to more intensive screening. But that's a really big question in terms of cost to society and how long we need to maintain screening. And it's very important in terms of education to tell our patients also when they do get vaccinated, they must continue to get screening. And I wish I could tell you at what interval, but I don't know the answer to that.
Okay, do we have any other questions? Yeah, all the way in the back.
I actually have two questions. One is that over time and in the future, would it be possible that this could be given as a childhood vaccines, like a lot of the early ones, with subsequent boosters, kind of like you do with a tetanus booster? Because another aspect that hasn't really been discussed here is issues of childhood sexual molestation and abuse. So pretty much the discussion has focused on consensual sex of teenagers, but I don't know the statistics of how common it is, but sexual abuse also cannot be ignored.
It seems like it seems like the question about whether it could be given in infancy will emerge the longer we have data about the length of protection, I would assume.
Are there any plans to do the studies earlier?
Like safety studies earlier? I don't know. Do you know?
I'm not aware.
Okay. The other question I had was in terms of your screening, you're looking at your cheese slide. Are there any I guess in development, any self-administered types of screening tools? For instance, like for STDs, you can have patients go to the lab and do a urine for gonorrhea, chlamydia, or in the SHARE study, some of the things that they're doing are doing mouthwash gargles to screen for oropharyngeal abnormalities and doing pap smears of those. Is there any kind of equivalent in development for cervical
Well,
abnormalities?
I think there's data being gathered in terms of efficacy of or an accuracy of self-screening for HPV. I think one big problem with a lot of the screens that we have is they very much over-identify risk. So that's the flip side. And an example I'll give you is PSA. If somebody's prostate-specific antigen goes up, yeah, they're probably at risk, but then you do stuff and you do stuff and you do stuff to them, and it's very expensive, and it very much over-identifies whether somebody's at risk. If you were to draw a Venn diagram of somebody who had an elevated PSA or somebody who had a positive HPV someplace, the fraction of people who had a positive test who were actually at risk would probably, it would be less than 5%. So we do need to identify better predictors of risk for disease. It's possible to put a Q-tip someplace and find HPV, but whether or not that actually identifies somebody who's at risk for disease, it's not linear.
We do have another question online. I think I had heard you say that the vaccine is good for 5 years. Does that mean that the teen will have to repeat the vaccine after 5 years, or is there a booster?
Getting data.
Yeah. I should really let Connie answer this because this is more her world, but my understanding it's just simply how long the studies, the follow-up has been done. So I think, the hope is the longer people are followed and show that they still have protection, the longer we'll know the vaccine lasts without the need for a booster, but I think the data are being collected.
Okay. And do we have any other questions here? Yeah, all the way in the back.
I just wanted to say it was a great opportunity to be able to talk to it, to listen to this. And I think that it does highlight the need for a lot of activism around education for the need for HPV vaccination and, of course, screening. We're going to have to get a lot of education out there. I understand concerns about thinking about mandating before the general public really knows about this. But then again, we've ceded the floor to some of the anti-vaccinationists on this already with what happened in Texas, where Governor Perry went back on his efforts to mandate, well, it was mandated. He mandated it, but then the Texas legislature withdrew the mandate. So we need to work on a lot of education. I also wanted to highlight, again, from the provider point of view, my point in trying to say that the individual provider is maybe not and it currently is the only source of vaccination, either in the public or the private sector, is that our primary care resources are being quite strained in the U.S. And so to build a program on something that I can tell you is really struggling, I can tell you I'm probably an obsolete beast being in solo private internal medicine practice because it's not viable and we're all going to have to join groups. I think it's an important thing that I hope I was able to communicate. And again, as a public health issue, this should be taken up more by public health providers. Thanks.
Okay. I think that wraps it up for today. I really want to thank once again Drs. Connie Trimble and Nancy Cass for an excellent presentation, and thank all of you for coming, and we hope to see you again next month. Thank you very much.